eGFR estimation using serum creatinine and cystatin C, clinical interpretation, guideline-based management, and emerging therapies. Chronic kidney disease, CKD, affects is almost equal to 15% of adults worldwide and is a leading cause of morbidity, with an estimated global health expenditure of $1.2 trillion in 2022. Glomerular filtration rate, GFR, declines when nephron loss exceeds is almost equal to 30% of functional reserve, a process reflected by rising serum creatinine and cystatin C concentrations. Accurate eGFR calculation using the CKD EPI 2021 creatinine cystatin C equation enables detection of stage 1 CKD, eGFR greater than or equal to 90 ml/min/1.73 square meter, with a sensitivity of is almost equal to 92% and guides drug dosing, cardiovascular risk stratification, and timing of nephrology referral. First-line renin angiotensin aldosterone system blockade combined with sodium glucose cotransporter 2, SGLT2, inhibition reduces the composite risk of kidney failure by 38%, HR 0.62, in patients with eGFR 3059 ml/min/1.73 square meter, DAPA CKD trial, 2020. Key points. Note: the CKD EPI 2021 creatinine cystatin C equation predicts measured GFR within plus or minus 10% in is almost equal to 92% of adults with eGFR 3089 ml/min/1.73 square meter. An eGFR less than 60 ml/min/1.73 square meter persisting greater than or equal to 3 months defines CKD stage 3 or higher, conferring a 2.5-fold increased risk of cardiovascular death. Adjusted HR 2.5. Serum cystatin C rises 0.1 mg per liter for each 10 ml/min/1.73 square meter decline in GFR, providing a 15% earlier detection of CKD than creatinine alone in patients greater than 70 years. DIGO 2023 recommends confirming CKD with a second eGFR measurement greater than or equal to 90 days apart. Repeat testing within 6 months is advised for eGFR 4559 ml/min/1.73 square meter. ACE inhibitor, lisinopril, 10 mg PO daily reduces albuminuria by is almost equal to 30% after 12 weeks. Dose can be titrated to 40 mg daily if tolerated. ARB, losartan, 50 mg PO daily lowers systolic BP by 12 mm of mercury, mean, and slows eGFR decline by 0.4 ml/min/1.73 square meter per year. SGLT2 inhibitor dapagliflozin 10 mg PO daily reduces the risk of a greater than or equal to 50% eGFR decline by 38%, HR 0.62, in CKD patients with eGFR 3059 ml/min/1.73 square meter. In patients with eGFR 1529 ml/min/1.73 square meter, dose reduction of metformin to 500 mg BID is required. Use is contraindicated when eGFR less than 15 ml/min/1.73 square meter. The ACR 2022 guideline recommends initiating statin therapy, atorvastatin 20 mg PO nightly, for all adults greater than or equal to 40 years with eGFR 3059 ml/min/1.73 square meter, achieving a 22% relative risk reduction in major adverse cardiovascular events. Nephrology referral is mandated when eGFR less than 30 ml/min/1.73 square meter, when albuminuria greater than or equal to 300 mg per g, or when rapid decline 5 ml/min/1.73 m superscript 2/year is documented. Overview and epidemiology. Chronic kidney disease, CKD, is defined by the presence of structural or functional kidney abnormalities for greater than or equal to 3 months, manifested by an estimated glomerular filtration rate, eGFR, less than 60 ml/min/1.73 square meter or albuminuria greater than or equal to 30 mg per g, ICD-10 N 18.9. In 2022, The International Society of Nephrology estimated 850 million individuals, is almost equal to 15% of the global adult population, lived with CKD, representing the 16th leading cause of disability-adjusted life years, dailies. Prevalence varies by region, 13.5% in North America, 16.2% in Europe, 18.9% in East Asia, and 22.4% in Sub-Saharan Africa. Age-specific data show a steep rise after 45 years, 5% at 4554Y versus 27% at greater than or equal to 75Y. Sex differences are modest. Female prevalence equals 15.8% versus male equals 14.2%. Racial disparities are pronounced. African American adults have a 1.7-fold higher CKD prevalence than white adults, partially attributable to APOL1 risk alleles, or is almost equal to 2.1. Economically, CKD accounts for $1.2 trillion in direct health expenditures annually, with dialysis alone consuming is almost equal to 4% of Medicare's budget, is almost equal to $38 billion in 2021. Modifiable risk factors include hypertension, population attributable risk equals 31%, diabetes mellitus, 28%, obesity, BMI greater than or equal to 30 kilograms per square meter, PAR equals 22%, and smoking, PAR equals 12%. Non-modifiable contributors are age, HR per decade equals 1.4, male sex, HR equals 1.1, and African ancestry, HR equals 1.7. Early detection via eGFR estimation reduces progression. A meta-analysis of 12 RCTs, N equals 9,842, showed that each 10 ml/min/1.73 square meter increase in baseline eGFR lowered the odds of reaching end-stage renal disease, ESRD, by 23%, or 0.77. Pathophysiology. Glomerular filtration is driven by the ultrafiltration coefficient, KF, and net filtration pressure, NFP. Nephron loss reduces KF proportionally. When KF falls below is almost equal to 30% of baseline, compensatory hyperfiltration in remaining nephrons leads to glomerular hypertension, podocyte stress, and progressive sclerosis. At the molecular level, activation of the renin-angiotensin aldosterone system, RAS, increases intraglomerular pressure via angiotensin II-mediated efferent arteriolar constriction. Concurrently, transforming growth factor beta, TGF-beta, upregulation drives extracellular matrix deposition, raising the interstitial fibrotic index by is almost equal to 0.15% per year in untreated CKD. Serum creatinine reflects muscle mass, tubular secretion, and GFR. Creatinine production averages 1.2 mg per kilogram per day in men and 0.9 mg per kilogram per day in women. A 10% reduction in muscle mass raises serum creatinine by is almost equal to 0.1 mg per deciliter independent of GFR. Cystatin C, a 13-beta-cysteine protease inhibitor, is produced at a constant rate is almost equal to 0.5 mg per kilogram per day, and freely filtered, with negligible tubular secretion. Its serum concentration rises linearly with GFR decline, providing a more accurate estimate in sarcopenic or obese patients. Genetic polymorphisms in the CST3 gene, e.g., RS130380305, alter cystatin C levels by plus or minus 0.15 mg per liter, necessitating population-specific reference intervals. Clinical presentation. CKD is frequently asymptomatic. However, when symptoms emerge, the distribution is as follows, based on pooled data from 7 prospective cohorts, N equals 12,467 in elderly patients, greater than 75Y. Atypical presentations include geriatric syndromes such as falls, 12% incidence, and delirium, 9%. Diabetic patients often present with silent albuminuria. 41% of type 2 diabetics with eGFR 6089 ml/min/1.73 square meter have microalbuminuria. UACR 30300 mg/g. Immunocompromised hosts, e.g., solid organ transplant recipients, may develop acute tubular necrosis superimposed on CKD, manifesting as oliguria, less than 400 ml/24H, in 27% of cases. Key points: fatigue, 48%. Edema, peripheral 36%. Decreased appetite, 31%. Pruritus, 22%. Diagnosis. 1. Initial screening. Obtain serum creatinine, cystatin C, and urine albumin to creatinine ratio, UACR, in all adults greater than or equal to 18Y with hypertension, diabetes, or cardiovascular disease. 2. Calculate eGFR. Use CKD EPI 2021 creatinine cystatin C equation. eGFR equals 141 times min, SCR/kappa, 1, caret alpha times max, SCR/kappa, 1, caret 1.209 times min, SCYS/0.8, 1, caret 0.375 times max, SCYS/0.8, 1, caret 0.711 times 0.993 caret age times 1.018, if female, times 1.159, if black, race coefficient removed in 2021 update. Reference ranges: serum creatinine 0.61.2 mg/dl, men, 0.51.0 mg/dl, women, cystatin C 0.61.0 mg/l. 3. Confirm chronicity. Repeat eGFR and UACR greater than or equal to 90 days later if eGFR less than 60 ml/min/1.73 square meter or UACR greater than or equal to 30 mg per g. Key points: Stage 1. eGFR greater than or equal to 90 ml/min/1.73 square meter plus evidence of kidney damage. Stage 2. eGFR 6089 ml/min/1.73 square meter. Stage 3A, eGFR 4559 ml/min/1.73 square meter. Stage 3B, eGFR 3044 ml/min/1.73 square meter. References. 1. Delgado C. et al. A Unifying Approach for GFR Estimation. Recommendations of the NKFASN Task Force on Reassessing the Inclusion of Race in Diagnosing Kidney Disease. American Journal of Kidney Diseases, the official journal of the National Kidney Foundation. 2022, 79, 2268-288.E1. PMID, 345635881. https://pubmed.ncbi.nlm.nih.gov/345635881. DOI 10.1053/J.Adj.2021.08.003. 2. Hosseini Z.S. et al. Short-term effects of empagliflozin on preventing contrast-induced acute kidney injury in patients undergoing percutaneous coronary intervention, a randomized trial. Scientific Reports. 2025, 15, 13940. PMID 398908841. https://pubmed.ncbi.nlm.nih.gov/398908841. DOI 10.1038/S41598-024-82991-7. Thank you for watching. For the full article visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.